My dear students, in this video, I am going to discuss something about the careful interpretation of laboratory tests in the ICU. So I will go through a case, and at the different stages of the illness course, you will find the tests which show a result which is incongruous to the clinical examination. And just it's a template on the basis of which you can understand how the changes reflect and how the appropriate laboratory tests can be missed, and they should not be missed unless they corroborate with the clinical condition of the patient. Let us see the case. A 61-year-old male, Mr. Roy, was brought to the ED after being rescued unconscious from a house fire. On checking background, he is a type 2 diabetic, insulin naive, poorly controlled. He also had alcohol-related cirrhosis with child poke B and was also having low muscle mass or sarcopenia. The injury that he sustained was open tibial fracture with active bleeding sustained during the act of rescue. The disposition was that he was admitted directly to the ICU for airway protection, hemodynamic monitoring, and fracture stabilization. So this was the situation in day 0, and when the patient was arrived in the ICU, his mental status was that he was having a GCS of 10, appeared confused, was also complaining of headache. The vitals revealed a heart rate of 128 per minute, BP of 92/58, respiratory rate of 26 per minute. The injury on examination was an open tibial fracture with active external bleeding. The exposure he had was that he was rescued from a smoke-filled room. Now, two normal laboratory results came back within the first hour. So if this is the case, what are the things that we should look? So the two things that would matter at this point of time, one is the oxygen delivery despite the smoke exposure, and another is the hemoglobin despite the active bleeding. So on arrival, we look at the SpO2 was 98%, PO2 was 95, mm of Hg lactate was 6 millimoles per liter. And the clinical state, as I said before, was confused, complaining of headache with a GCS of 10. At this time, the reading by the physician was that oxygenation is normal. The confusion is probably from head injury. Now, is this really so? If we look that the patient was rescued from the smoke-filled room, the condition that first strike comes to our mind is carbon monoxide poisoning. So if you look the mechanism of carbon monoxide poisoning, we see that the standard 2-wavelength pulse oximeters cannot distinguish carboxyhemoglobin from oxyhemoglobin, and a routine ABG's PO2 measures only the dissolved oxygen, so neither detects the carboxyhemoglobin. The clue obtained in this patient was of exposure history to smoke, altered mental status, and headache out of proportion to the normal oxygenation, and an unexplained rise in lactate. So in this condition, it was requested to co-oximetry to measure the carboxyhemoglobin directly and start high flow with 100% oxygen empirically while awaiting the level. So the teaching part would be that a normal SpO2 and a PaO2 are exactly what carbon monoxide poisoning looks like. So they are not exculpatory. We need to exclude by doing a co-oximetry and take the necessary steps. The next abnormality that was detected next day was a normal hemoglobin despite active bleeding. Hemoglobin on arrival was 13.5. The baseline hemoglobin, which was reported after checking his past records, appeared to be 14.2. There was ongoing external bleeding from the open tibial fracture. The vitals revealed a blood pressure of 92/58 and a heart rate of 128, as I told. And the team's reading was that hemoglobin is fine and the transfusion is not needed yet. Now, this is again another mistake because always hemoglobin lags behind blood loss. The mechanism is that when acute hemorrhage loses whole blood, both cells and the plasma proportionately, hemoglobin concentration only falls once the transcapillary refill and the resuscitation fluids cause hemodilution, which occurs hours later. So this patient gave us some clue. He had tachycardia, he had narrow pulse pressure, he had a rising lactate or base deficit, and the mechanism of injury did not get a single hemoglobin value. So we have to treat the hemodynamics and trend, repeat hemoglobin after 1 to 2 hours of resuscitation or imaging to gauge the true blood loss, which may get mixed in this hemoglobin at this stage. So the teaching pearl remains that in acute bleeding, hemoglobin is a lagging indicator. It is not a real-time one. So we will have to repeat the hemoglobin after 1 to 2 hours of resuscitation. Next day, the patient had a glucose of 480 milligrams per deciliter with an arterial pH of 7.02. The breathing pattern was Kushmal breathing, but the serum potassium was 4.6 millimoles per liter. The physician's reading assessment was that potassium is normal and we can start insulin infusion without extra precautions. But this is the wrong because potassium always hides a deficit. It doesn't, but not a surplus. The mechanism is the acidemia and insulin deficiency shifts potassium out of the cells, while osmotic diuresis drives ongoing renal loss. So a total body deficit of roughly 3 to 5 millimoles per kg can hide behind a normal serum level. Now, the clue which this patient was giving was the severity of acidosis, osmotic diuresis on history, and the plan to start insulin, all of which will rapidly shift potassium back into the cells. So the next action would be to recheck potassium every 2 hours during the first 6 to 8 hours of the DKA management and replace proactively before it falls and never to be contended with that normal level. So a normal potassium in DKA is a warning of an impending fall. It is not a reassurance of normal potassium. Again, next day, coming day, the patient had wound sepsis and persistent vomiting. So the clinical course was of infected wound vomiting, diuretics for fluid overload was being administered. The arterial pH was 7.38. PaCO2 by Burkhardt was 40 and 24. The anion gap was 11 millimoles. At this time, the physician's reading was that the acid base looks fine with pH, bicarbonate, and anion gap all within the range. But you have to remember that 3 disorders cancel out to look normal. A metabolic alkalosis with vomiting or diuretics produce a high anion gap metabolic acidosis because of sepsis with the lactate rising and respiratory compensation. They are occurring simultaneously. And when they're occurring simultaneously, one is offsetting another. So the patient gave us clue that more than one plausible acid-base insult in the history. We should calculate the delta gap and an albumin-corrected anion gap rather than trusting on the raw numbers of ABG that we get. And accordingly, our action should be work out expected compensation and the delta ratio explicitly and check lactate directly instead of inferring it from the bicarbonate or anion gap. So the teaching pearl remains that a normal pH only tells you the net result, and you do not know how many opposing storms are producing this net result. So we have to search independently. Next, the patient is found on DVT prophylaxis on unfractionated heparin. The baseline platelets on day 0 are 4 lakhs. The platelets on day 8 are 1.6 lakhs. The laboratory reference range is 1.5 to 4, and the relative fall from the baseline is around 60%. And the team's take on that was the platelets are within normal range, so there is no cause for concern. But you have to remember that a normal count can still be more than 50% fall. So mechanism is that whenever there is hit, it is defined by a relative fall from the baseline. There is not an absolute threshold. So a high starting count can drop by half and still sit inside the reference range. That is, it may be normal. So the clue in this patient was this onset was 5 to 10 days after heparin exposure. So any new thrombosis and no other explanation, the 40s score is built on the relative drop. So we have to do the scoring, and action would be to always compare against the patient's own baseline. If 40s is intermediate or high, we have to stop heparin, send HIT antibody testing, and start a non-heparin anticoagulant. So the teaching part would be that normal for the lab is not normal for the patient. Always trend platelets against baseline when on heparin. Next, if you see the patient coagulation profile before a bedside procedure, which was planned in the successive day, was a diagnostic paracentesis for ascites. The INR was 1.6. The platelet count was 90,000. Liver status was, again, as I mentioned before, alcohol-related cirrhosis with child cook 2. The physician's reading at the bedside was that it is not too bad, and if we should proceed with correcting the INR without correcting the INR or the platelets. But the INR measures only half the seesaw. The INR reflects only the procoagulant factors that are vitamin K, DPN 2, 7, 9, and 10. It ignores the parallel fall in protein C. It ignores the fall in protein S and antithrombin, as well as the rise in the von Willebrand factor or factor VIII. So this is what is called rebalanced hemostasis. So the clue was that the INR does not correlate with procedural bleeding risk in cirrhosis, because a pooled ratio or the odds ratio was 1.5 in a study which was not significant across 13,000 patients. So we do not routinely correct INR for platelets before low risk procedure based on the number alone, and use instant TEG or ROTEM. These are the viscoelastic testing when it can change the management. So a normal looking or a normalish INR can hide either bleeding or thrombotic risk in a patient with liver disease. Now this patient, subsequent days, has oliguria with a reassuring creatinine. Urine output is less than 0.3 ml per kg per hour for 8 hours. Serum creatinine is 0.7. Body habitus, as I mentioned, is sarcopenic, that is cachectic with low muscle mass, and the concurrent state are of sepsis and cirrhosis. And the team takes the condition on papers as renal function is fine, creatinine is normal. Now, this creatinine is always weighted by muscle mass. Creatinine generation is proportional to the muscle mass. In a sarcopenic cirrhotic patient, true baseline GFR is already lower, and a fall in GFR produces a small creatinine rise than in a muscular patient. So this patient gave a clue that he is having low muscle mass on exam. The oliguria, despite a normal creatinine, and sepsis as a known AKI risk factor. So always the action would be not to rely on isolated creatinine value, trend creatinine and urine output, and consider cystatin C or sarcopenia index when the muscle mass is in doubt. So the teaching part would be that in a patient with little mass, normal creatinine may already mean abnormal kidney function. So if we go through this case, the 7 changes one by one along the days, you can see that on the day 0, where the patient had a saturation of 98% and a PO2 of 95, the hidden abnormality was a carbon monoxide poisoning, and there were sufficient clues which the patient gave. Same was about the hemoglobin, which was apparently high despite an ongoing hemorrhage. On day 1, patient had a normal potassium with totally depleted potassium because of DKA. Between day 3 to day 5, patient had a normal looking pH with a normal anion gap with triple mixed acid-base disorder, all moving in opposing directions to nullify and bringing a normal picture. INR found as to be 1.6 because of rebalanced hemostasis in cirrhosis, and later a normal creatinine, which was occurring despite a sarcopenic AKI in a patient with cirrhosis and sepsis. So the teaching pearl is that across these 10 days, not one of these 7 normal values ever crossed a lab's alert threshold. Yet each one marked a distinct and high acuity ICU emergency. So whenever we settle for the lab values, we will have to correlate with the patient's existing clinical condition and then reassess and understand the lab values with a greater clarity. If so, a single normal value is a snapshot and not a verdict. It should be weighed against the trend, baseline, and clinical context. Hemoglobin, potassium, platelets, INR, pH, anion gap, SpO2, PO2, and creatinine. These are all very simple tests, but yet they can conceal and they're structurally capable of looking normal while hiding serious pathology in the patient. So when the clinical picture and a normal lab disagree, you have to trust the trajectory and confirm with a second, more specific test and see how it correlates with the patient's clinical condition. You can read this book, Interpreting Laboratory Tests in Intensive Care, for more such examples and more such clinical conditions where proper and careful interpretation of test results can save the patient and guide treatment. Thank you.